Okay, good afternoon. My name is Joaquin Machado. I'm the Director of Nursing at Serenity Walks Wellness Center in Fort Lauderdale. And today we will talk about suicidal risk assessment. Why it is important for us to know the risks of suicidal in our patients and clients if we are not a crisis unit. Because in healthcare, in behavioral healthcare, we always associate suicidal, Baker Act, crisis unit. And we are not a Baker Act receiving facility. We are not a crisis unit. Why do we have to know, and why it is important for us to know about suicidal risk in a client? It's very simple. We receive clients who are coming most of the time after a recent use of drugs and alcohol. Clients who, in 99.99999%, they have concurrent diagnosis. And we already know what is a concurrent diagnosis. It's a combination of addiction and mental health issues. Why it is so frequent? Because it's a cycle. Individuals who have mental health issues or mental health diagnosis, they are more at risk to go into addiction. Why? Because lack of judgment, because trying to avoid symptoms of the mental condition. And at the end, the cycle is created. And why addiction patients can end with the behavioral mental health diagnosis? Because the deterioration of the central nervous system caused by the drug and or the alcohol. After years and years and years intoxicating the central nervous system, we will see psychiatric decompensations or psychiatric diagnosis. So our clients, they come here with a variety of symptoms and signs that put them at risk to have suicidal thoughts. And some of them, as you know, that when we conduct the assessment, they have already history of previous suicidal attempts. By overdose or by other means. So it is important for us to know if there is any possibility, any risk of suicidal ideation, suicidal thoughts, or suicidal intent in our clients. This is one of the most important parts of safety in behavioral health care. And that is why you see how our clinical director, our medical director, our director of nursing, we are very straight in the way that the assessment has to be conducted and in the result of the assessment. And all the precautions that have been taken when the patient scores higher in the risks of suicidal. Now, the first question: Have you wished you were dead, or wish you could go to sleep and not wake up? Yes or no? And there is a score for that. Why that question is important? Because in individuals who have deep depressions or they experience high levels of anxiety, this is frequent. Depression is one of the worst episodes that may happen to a patient. You don't see that there is a future. You are unable to see the light at the end of the tunnel. And besides that, if you have problems, environmental, family problems affecting you, it is not infrequent that the patient one day say, I wish that I will not wake up, or I wish that I've been dead. Because doesn't find the solution for the problems that they have in life. Anxiety, when goes to the level that is not, the patient cannot take it, can also produce suicidal ideations or wishes of death. Now, it is important for us to know if at the moment of admission, when we are in front of the patient, if the patient have any thought of suicidal or wishes of being dead, some of everything related to suicidal ideation. So because that is the beginning of what we call suicidal risk factors. And we activate our suicidal risk precautions. When the individual in front of me say, yes, I'm having suicidal thoughts. Well, besides that, and the way I see the patient, that patient maybe meet criteria to be backed up and transferred to a crisis unit, because we will be unable to provide here the level of suicidal risk precaution that that patient needs. Until that episode is controlled and the patient comes back to us. Have you been thinking about how you may kill yourself? Some patients say yes. In our environment, it's the most common is yes. I was thinking to take all my pills or to OD. That is another factor. Even if at the moment of admission the patient doesn't have those thoughts, that happened in his mind time ago, recently or no, but already happened. So this is another factor I have to take into consideration. Have you had these thoughts and had some intention to acting upon them? It's not the same when the patient has suicidal ideations. When the patient has suicidal ideation with plan, which is patient is thinking how to do it, and when the patient has suicidal ideation with plan and also able to act upon those thoughts. Sometimes individuals, they have good control and they say, no, this is my desire, but I will never do it. Because I think of my children, I think of my parents, I think of my friends, or whatever. Which is what we call protective factors that we will see now. Have you started to work out the details of how to kill yourself? Sometimes the individual start collecting pills. We have seen that even here in our environments. They check the pills, they start collecting the pills, and that is very suspicious. Why you are putting all this bunch of pills together? Sometimes they don't go far further than that, but sometimes yes. So if the individual say yes, one day I took all my pills and I put it right in, but at the end I didn't take it. I stopped. But that individual was going into the last step. Have you ever done anything, started to do anything, or prepared to do anything to end your life? For example, patients start calling people, or the individual start calling people, and then, people who maybe they were not in touch, individuals, it's like a saying goodbye to everybody. At home, they prepare things, what they want for one person, what they want for another person. Preparations that are not usual and correspond to the ideation of death. It is important for us to know when that happened. It was recent, it was years ago, it was last year, it was last week. Because of course, it will not have the same significance. If you tell me, yes, I was collecting all my pills to take it together last week, and when I say, well, 5 years ago, yes, I was thinking about that. It doesn't have the same repercussion. This question, I always, okay, if you try to attempt against yourself in the last 24 hours, that immediately is Baker can go to a crisis unit. But that question, do you plan to harm yourself or somebody else in the facility? Sometimes I think that question is a little bit silly, because most of the people, they don't say yes, even if they want to die. Because if you really want to die, you will try to make it in the way that nobody will know until the end. Those individuals that they show how they want to die, most of the time, what they are doing is seeking attention. But guess what? That is more dangerous. Because trying to seek attention, they will die. But they will die because of miscalculation. I will take a bunch of pills, and let me see, because in 10 minutes my family is arriving. And they will find me, but maybe that they had a flat tire. And they don't come in 10 minutes, and I die. So that is what I call suicidal, due to miscalculation. Or they will find me with the people, they didn't go to that room because somebody called and they were on the phone for 20 minutes, and you die. Be careful when you see patients that have reasons to die, reasons to be suicidal, but they try to feel you that how happy they are and how wonderful they feel. Those, be careful. They are trying to trick you to do what they really want to do. If you see here, we have symptoms and signs that are mild or severe. Symptoms and signs that we know are related to the intention of dying or suicidal or inducing suicidal thoughts. Depression, hopelessness, humiliation, frustration, anhedonia, helplessness, guilt, shame, impulsive anger, insomnia. Guys, insomnia, chronic insomnia is very destructive. Very destructive and produce a lot of anxiety in the individual. Then, of course, when the patient has alteration, What do we call alteration in thought process? Hallucinations and delusions. That individual is out of his mind. So everything is possible. When the mood is affected, anxiety, agitation, panic attacks. Listen, anxiety, a panic attack, the individual thinks that is dying. And when it's very frequent, sometimes they cannot take it anymore. Anxiety, high anxiety, the same. One of the reasons, and not related to mental health, in medical surgical, patients who have hyperfunction in the thyroid gland, when the level of hormone inside the body is so high, they go into what is called thyroidal storm. And the patient, one of the risks is suicidal, because they cannot resist the level of anxiety that that issue will produce. And most of the time when they are not well cared, they kill themselves. For real. Now, let's go to talk about protective factors and risk factors. All these factors that we already have mentioned are risk factors. But for our assessment to be valid in healthcare, has to comply with what we call safety assessment. And a safety assessment needs to have a combination of risk factors and protective factors. And the evaluation of both in a scale is what will tell me the real risk of the patient to commit suicide. What do you think will be protective factors? Protective factors mean to make the patient not suicidal, or to make the patient not act upon the suicidal thoughts. What do you think? Protective factors.
Family.
Huh?
Family.
Family? When you have dependents, you know that some people depend on you, you cannot die. Let me tell you something. When I was practicing as oncologist, I have patients that I didn't realize how could be possible that they stay alive that long, because they were full of metastases. And they stay alive because they knew that they have dependents. And they knew that their children need them. And it is incredible the power that issue, that specific factor has. Pets, satisfaction with job, religion, community ties. All these are protective factors. And I always insist to my nurses, protective factors are as important as risk factors, because the combination of both will tell me at the end what do I have to do. In our facility, we have the policy that if the patient scores up to 5, we have to communicate the team, but the patient will be observed and reassessed later on. But if the patient scores 10 or above, the patient has to be evaluated by our clinical director. The patient will go immediately into suicidal precautions, has to be, of course, from 5 up to 10 or 13. The patient has to have in their treatment plan the suicidal risk. And if our clinical director determines that the patient is really actively suicidal, the patient will be taken out and transferred to a crisis unit facility. This is what we do here, and this is the importance of what we do when we do the suicidal risk assessment. Questions? Okay, no questions. Thank you very much.